Good afternoon. This is episode 3 of On the Sofa with Rouge and the Specialist Medical Group and the GibMed Hospital. And today I'm here with radiologist, senior radiographer, and I think in charge of this department, is that right?
Yes,
good. Toni, Valarino, Sanderson. And it's really exciting because I know Toni and I know what a journey it's been for her to get here and to run this department. So I want to hear all about it. I also am interested in the state-of-the-art equipment that we've heard David talk about and Patrick talk about. Toni is really the one who can tell us about it because she's using the machines every single day. So hi, thank you so much for being here. You've been on quite a journey. I know we've had many conversations in the past, and you came because you lived in England for a while. So just tell me a little bit. You're from Gib, obviously.
Yes, I'm from Gibraltar, and I left a very long time ago to go to uni, like most kids do nowadays. And I stayed in the UK for 26 years.
Wow.
Came back 2010.
Okay.
And my first job was with David as a receptionist downstairs in his first
Specialist
clinic.
Medical Clinic.
Yes, downstairs, and worked there as a receptionist for a few months, and then started doing private ultrasounds because I'm a qualified radiographer and advanced practitioner in ultrasound. Did that for 5 years. Then I went off to start at Pride Park as the best.
I remember that. That's when, I think I met you somewhere along the way and I was like, why are you going there to work?
So we did
when you were a radiographer, yeah.
Yeah, so I did that for 3 years, and then I got a phone call and I went to the GHA, forming part of the team for clinical governance. So COVID hit, so we stayed on. And then David called me 22 years ago now, 3 years ago. 22, I think it was, 21. And he said, that hospital I spoke about was starting it. Do you want to come and start up the X-ray department? So
yes, you had to say yes, of course.
Yes.
We talked to David. We had a podcast with him telling us how excited he was about this baby of his that he'd thought about for so long and how he wanted it to be a big success and how really there's nothing like this in Gib, especially not in the centre of town.
No.
What drives your job? I mean, what is the thing that you enjoy the most about it?
The patient contact, the people contact, the talking to patients. So it's taken me back around 40 years to where I first started. It's getting to know that person and helping them along their medical journey, which sometimes is not very easy.
Yeah, so it is a difficult job, really, because you're dealing with people's day-to-day ups and downs.
Yes, absolutely. And you only get a snapshot. So an X-ray might take 5 minutes, an MRI might take 40 minutes, but it's just one little snapshot of that medical journey.
And why did you want to study radiography?
It was my backup plan.
Okay.
And I went to the hospital and I met Hereka Gabai at the time. She was the lead in the old hospital. Annie Doma, who retired a few years ago, was there, just come back from studying, and I enjoyed it. I met a radiologist that used to come out every 3 months to do the more interventional stuff, a guy called Jim Hinton from the Royal Free, and that was it. And I went back.
Went to England,
and I went to the Royal Free and I studied there.
And how long is the course? I mean, how long do you study
it's
for?
3 years. It's an undergraduate. It's a BSc, 3 years. Yes.
And do you have a speciality, or is it just?
No, I specialised in ultrasound. So
okay.
All aspects of ultrasound except obstetrics. So I'll do the gynae, the abdominal, the vascular, and musculoskeletal. So that's like an advanced practitioner role.
Okay, so you end up here at the GibMed Hospital, well, Specialist Medical Clinic.
Yes.
So how does that differ? Because a lot of people ask me, like, I know they're both part of the same group, but I suppose it's just visits with doctors at the Specialist Medical, and then if you need anything else, you come here. Is that right?
That's correct. Downstairs is predominantly a primary care facility. You've got your GPs, your physios. Up here on the second floor, which used to be the LPCC, we've got the radiology department one side and the new, hopefully to be opened soon,
hospital,
the surgical rooms and the overnight stays. Yes. I think it's a week maybe away from it. Yeah.
Really?
It's
so
not that far away.
We spoke to Patrick a while ago, like maybe a couple of months or 6 weeks ago, and he was so excited. And after the podcast, he took me around.
Yeah.
I mean, it's really spectacular.
I bet if we went around now,
the bed's in now because it was like
and it's all decorated. So it's looking quite spectacular. actually. Yeah.
So tell me a bit about your average day, Toni, because I mean you work every day, I suppose.
We work every day. There's a team of 2 admin girls, and I've got two a radiographer and an MR operator, and we work together. So the average day, come in, have a look at the lists.
Yeah.
And then we split ourselves. So I'll come in and maybe do some X-rays or ultrasound, and the other 2 chaps will be doing the MRI, or one will doing CT, and one will be just hanging around helping. So there's 6 rooms, so we're doing all different modalities and different imaging. Our main workload is the MRI machine.
Yeah.
But every other modality seems to have increased recently.
Really?
Yes, and I think it's because the facility, like you said earlier, it's in the middle of town.
Yeah.
And it's here.
Well, we've had this conversation with Patrick. I mean, people go to Spain to have all kinds of beauty treatments.
Yeah.
You know, and now they can have whatever, you know, even medical treatments, they can have it here. Why get in a queue and go to Spain?
Exactly.
You can have it done here.
Facilities are here. They're very new facilities, new equipment.
I can see. You've got to tell me what all these are. But you've said you've got 6 rooms. So 6 rooms for 6 different machines. Wow.
So there's the X-ray machine. This is the grandfather, great-grandfather of them all. This is how it all started. Plain X-ray, plain radiography.
Ah, that's what this room is.
That's what this room is.
But there are different, I suppose, for different parts of the body.
No, this is for different positioning.
Right,
so
yes.
Either standing up, which
okay.
chest X-rays normally over there, or your spines and stuff, or you're lying down behind you, and also for extremities as well. So this is just different positioning.
Yeah, amazing. And what's this one for? Standing up there?
That's a long spine board, which we're not doing them just yet, but that's so that you can pop that in front of that and you can get a scoliosis patient who get the whole spine done. But we're not using that yet.
So how do you differ from the GHA compared to the equipment that they have in the hospital here?
I haven't visited recently. I know they're having a new new equipment, newly installed equipment. They're upgrading, which is great for them.
Yes.
They've got some general rooms. I think they used to have 2. They've got specific fluoroscopy room. They've got more than what we have. Obviously, there might be 2 X-ray rooms, 1 fluoroscopy, 2 ultrasound rooms. The only thing we have that's not available there is the MRI scanner and the DEXA, the bone densitometry scanner as well.
Oh, the bone dens. Yes, I know a lot of people who have had that done.
Yes, so we've got that as well. So the 6 rooms are this one: CT, bone densitometry, MRI, ultrasound, and we've got a C-arm fluoroscopy area as well.
Okay, and are you getting a lot of patients from the GHA who are coming now?
Yes.
Because I remember we had this conversation how you felt it was like super important that you know patients could come here and that you could help them
with referrals. Yeah,
I'm so glad.
Yes, and yeah, we've got a great working relationship with them.
Great.
So yes, our referrals have just shot through the roof, and people are appreciating the fact they don't have to cross the border and wait across there and come back. And so it's like you said, half an hour, and then they can go back to work or carry on with their day.
Yeah, and I remember when the MRI was brought into the building, because I live quite near, I had this conversation with Patrick. It was like, I don't know, like the Three Kings cavalcade when this massive lorry came the wrong end of Main Street up.
Correct.
And we were looking out of the window thinking, what on earth is that? I couldn't believe the size of it. So I suppose if that's what sits outside this building that you see from casement, it's not there's like an area outside.
No.
Those are just the generators.
Generators, and then the different bits of electrical stuff. There's a quench pipe for the helium for the MRI. But no, it came in through the roof. It was dropped in wind swaying the crane, and got dropped in through the hole. Then adjusted it so that it was in the middle of the room, or where the most reinforced bit was, and then the roof was shut, because they call it a Faraday cage, which is so that the room is enclosed. There's nothing in there. Yes, it was a tricky operation. First we dropped in the CT scanner, and then you hold it across.
And what is so important about an MRI scanner? I mean, what are the kind of things that it detects compared to a CT scanner, for example?
It's better for your soft tissue.
The damage to your body when you have one?
No. Let's say you've damaged your knee, so it's better to have a look inside the soft tissue and see what the damage is.
Right.
It works. It also helps I'll do an ultrasound and I'll see a couple of lesions I'm not happy about. We can have an MRI of the liver and just to see what they are. So it supports other findings.
So it's
and there's no radiation.
Okay.
There's no radiation, so you're not using
Because
radiation.
with an X-ray you would get radiation, with a CT as well?
Yes, it's radiation. All the other machines are radiation based.
Yeah.
The use of ionizing radiation. The MRI scanner is the magnet. It's the energy from a magnet.
Oh, that's interesting.
Yeah.
But does it still make that?
All the time. It's on all the time. All the whirling. All
the whirring. Yeah, I've had a few. I've had a few for different things. But actually, they are fantastic at diagnosing results quickly, because at the end of the day, if you've got something dodgy, you don't want that to be lingering there without a diagnosis.
Exactly. I mean, at most machines, the diagnosis will be done quickly, but I suppose by the time you get into the MRI scanner, you can see what damage there is to the soft tissue rather than going through all the other imaging modalities to get there. It's great for musculoskeletal work. It's great for spine, disc, herniation, all the rest. You can't really see in a CT scan. A CT and X-rays will just tell you what's going on with the bones. So the MRI is the best.
And do a lot of people here have like problems where they would need to have like bone stuff done compared to maybe where you've worked in other places, or?
It appears to be more focused.
Really?
So I think by the time
maybe
they get us,
yes,
they're quite poorly. It's also
by the time they get here, you think?
Yeah, because each hospital has got its own policy. So, an example in the UK, if you went in for backache, they wouldn't send you for an MRI until you've been suffering in inverted commas for 3 months, because it'd go through all the other processes, maybe physio first and an X-ray. So because of the expense of an MRI scan, you seem to go through all the other cheaper ones before that. So, and also because the community tends to be a little bit more. I know that person. Oh, bless them, and you get closer to them.
You get a bit. Your heartstrings are pulled a little bit.
Like recede there. So.
And do you think people are coming for diagnosis sooner rather than later now? I'm not talking about the ones referred by the GHA, but the patients that come here, private patients, obviously with insurance or just paying themselves. Are they like quick to come?
They're quicker in a way, or we are imaging them quicker if they're coming through insurance patients, because we're not going through that said step of 3 months.
Yes.
So they might come might come and see one of our GPs, back pain, and we'll just MRI them rather than going through all the other ones, because we have that facility to have direct access to an MRI scanner. So I suppose, yes, it's quicker that way.
And all the reports and everything, you guys do that yourselves? So you've got an in-house team?
No, the reports, all the images are sent to a reporting service in the UK.
Oh, are they?
Yes, so they send across, and then they report on them and send us a report back, and then we send it on to a referring clinician. We come back in English.
So you're working with other hospitals as well?
We're working with a reporting service in the UK, and we work with other healthcare providers locally and actually across the border. We've done a couple of patients from across the border as well.
And are people from across the border coming here?
Yes.
To be treated?
Yes, because in fact there are people from here that have gone across the border and they want to have the imaging done here, so they come back again. Yes, and the other way as well.
Okay, and what other plans do you have for the department? I mean, you lead the department. You're saying you have a team of about 6?
Well, admin and clinicians, yeah.
Are you all the time looking to develop? To develop and to change?
And to meet this, because the demand of service is so great. So we're always trying to find creative ways of approaching that demand service. So, and anything else. So we as radiographers, we have to keep up with our own continuous profession development, any new changes, any new research, any different ways of working, any protocols. So we're always looking to see what the UK are doing, and then trying to implement it here as well.
So that is you personally and your team who are radiographers.
Yes.
So you need to kind of do courses. How do you?
It's online stuff. So it's like
you're reading a lot.
Yes, webinar stuff, research. Referrals. We work closely with the radiation protection advisors in the UK who might tell us, look, this has changed now, we've got to do this and that sort of thing. Yeah,
that's very interesting, because radiation is a big thing. people worry about the amount of radiation that you get in an X-ray. I remember once being told, "Oh, you know, you've already had it. You better not have another one." I was like, "But I really need one." How dangerous is it? Can you give us an idea?
It is dangerous, as in because the cells change, but you need to have quite a lot. Quite a lot. I mean, the amount of it nowadays that we use what's known as image optimization, so it'll reduce the dose and the least amount of radiation to get the image that's required to make a diagnosis. But you get a lot less from a chest X-ray than you would doing a transatlantic flight.
Yes. People don't realise that, I think. Flying gives you radiation. I didn't realise that.
Walking in Cornwall, apparently there's some hills and mountains that are
Really?
because of the minerals. You can spend time walking and get some radiation from that, which is much more like a chest X-ray.
But I suppose in the long run, it's much safer to have your diagnosis, to have it checked.
Absolutely.
If you're worried about the radiation.
I mean, everything we should be working with what's known as national dose reference levels, but it's very hard here to do that. So we tend to use the UK reference levels as this is fine, this is not fine. So yes, we're always on the lookout for safety.
Very good.
Yes.
What makes you a good radiographer?
Communication with your patient.
Really? And have you always been a good communicator?
No, you learn.
Really?
You learn along the way.
Were you shy? Quite shy when you were?
A story. So, very, very young radiographer, let's say in my first year. I always used to say to the patient, "That's fine, you can go now. Go back to see a GP in a week to 10 days. And this very elderly gentleman said to me, "That's fine because there's nothing in the X-ray," or "That's fine, you don't need to repeat the X-ray." And I thought, actually, that's a very good point. So I changed the ways I communicate to my patients. Instead of saying, "That's fine, you can go," it's like, "We don't need to take any more X-rays, you can go now." Because the patient could have interpreted it very different. So that's why I think the most important thing is how you communicate to your patient.
And I would never, ever, and I'm a good communicator, I would never have thought of something like that.
Yes,
because of course patients are coming to you who are concerned about their health.
Absolutely. Something so simple.
So you put, yes. That's a very good lesson learnt.
And the other one, as a sonographer, you're scanning away and you're in the dark and your face is illuminated by the screen. Then you sometimes do a little bit of that, a little bit of that. And I've always told my patient, ignore my facial expressions whilst I'm scanning you. It's just my way of concentrating. Because if you think about it, I'm doing that and I'm doing like that. You think, what's she seen on there? Can you see my hand going?
Yes, so it's true. No, it's true.
It's different ways.
When you have things like that done, you are looking at the person doing it, and you are thinking, "Can you see?" Because you're lying there, and you're a bit vulnerable. Actually, as a patient, you're lying there, and you're in their hands.
It's communication. I think it's communicating with the patient, explaining what you're going to do. I'm going to do this. I'm going to do that. I'm doing this because within the realms of not disclosing too much. As in too much medical information, and getting that informed consent, obviously.
And what do you do if you're there and you see something that's like quite dodgy?
You carry on, and as a sonographer and a radiographer.
What is the protocol?
The protocol's always been we'll send a full report back to the referring clinician.
You never tell the patient?
No, not if I see something there. No, it's not my place to do it.
Okay.
The referring clinician, I believe the referring clinician's got the complete picture. They might have bloods, they might have this, they might have the other. I may see a cyst, and I'm like, "You've got a cyst in the kidney." Whereas it might be, yes, don't worry about it. And then the doctor, the referring clinician, can explain to them not to worry and a little bit more, this is what we'll do.
So that's not really what you do. You just do the processing of the X-ray, of the MRI,
exactly, and then
diagnostic,
which was what we were saying. It's just part of their medical journey. This is your imaging, but I don't know what bloods have come back or any other tests that you may have done.
And as a person, what gets you up in the morning? What makes you like think, now I'm going to work?
I think it's I've always enjoyed radiography, but I think you need to go away to then realise how much you've enjoyed it. And I've been given that opportunity. I've started as a radiographer, done all my strategic stuff in the UK, working at health authority level, then doing my bursts a bit and all the rest. And it's that patient contact. It's sitting down and talking to the patient. And it sounds really cheesy, but coming back to the community.
here in Gib. It's like you're giving back. Oh, a little bit.
It is, because when I left, I signed a contract with the Department of Education that should the job come up, I'd have to come back, which is what you pay back.
Yes.
And this is what I think is the paying back, is being back and empathising, and the 40 years of experiences working in different areas, and like this, how you tell your patient to go away, or go and see your GP. That sort of thing. It sounds cheesy, but it is the job, basically job thing.
Would you do anything else? I know what you're going to answer. Maybe be a professional basketball coach. Because I know that.
I'm too old for that. No, I think this has been. It's funny. You just fall into it. Like I fell into it.
Yes.
It has been the right profession for me. I wouldn't, like I say, 40 years down the line, and it still makes me smile.
40 years. Said easily, isn't it?
It's 40 years since
It's incredible.
Yeah.
You're not that old.
Well, 40 years since I started as a student. So 84, see, I left in 1984.
Wow. What gives you the most joy, Toni? In general?
In general?
Yeah.
A patient's smile, and they're being grateful that you've helped them. Yeah. Again, it sounds really cheesy, but that smile, thank you, that was great. Or nowadays there's the MRI and claustrophobic patients, so you work with them.
Oh, that is I know, it really is claustrophobic.
Yeah.
How do you deal? I've always thought, do you reassure and calm people down?
It's different ways. Sometimes we've invited people to come up and have a look at the machine.
Yeah.
And have a sense of space and that, and without the anxiety I've got to go in there, or us rushing them, I've only got half an hour, you've got to go in. So we've given that, we've offered to, they lie down, they go in, we bring them back out again, how is that? And then we'll explain to them what we're doing. It's explanation, it's communication with the patient. We'll take them in and we'll talk to them and say, right, now we're going to do the first scan, the localizer, which is just identifying the area. And then when that's done, how you're doing? Okay, and the next sequence will be 3 minutes. So it's a song and a half, because they're listening to music. And we start working our way through slowly, breaking it down.
Yes.
And then suddenly we'll say, okay, we've got 3 sequences, 9 minutes. What do you want us to do? Go for it. Right, off you go.
That's really good.
And it's just having that voice at the end of the earphones. Yeah. And you say, there's something there. There's someone there. Not something, someone there.
Yeah.
And little tricks like that.
That's interesting.
Tricks. So,
and how does this department fit in with the rest of the whole picture, with the whole GibMed Hospital? I mean, with all the other things that are going on. So tell us a little bit about what's happening next. I know you said it's a week away from the surgical team.
I know we've got several documentation, like that. Yeah. But it's not far away.
Yeah.
So there'd be the day surgery that'll go on. There might be some, I don't know if David or Patrick has spoken about, knee replacements, for example, going in there. A radiography will have to go in to screen in whilst in theatre, so the surgeons can be in the right area.
Yeah, see, I'm actually
lining it all up. so that's our service expansion, in a way.
Yeah, of course, because you'll be dealing with patients who are staying.
I would have to be
checking there before and after, maybe operations.
Yes. So as radiographers, imaging has always underpinned all the other specialities. So at some point, you'll need some form of imaging.
But it's a vital part, really, because if they're doing a knee replacement, they're going to want to see the next day how it all looks in the knee.
Or any other, they're putting a rod down the leg, for example. They want to make sure that they're in the bone, and so.
As they should be.
Going injections into joint spaces for inflammation or whatever, cortisone injection. So we'll screen or we'll...
Because that needs to be done under ultrasound.
No, it can be done under X-ray as well.
Okay.
So that's what I mean by the C-arm. So it's live X-ray. So as they're injecting or positioning, you'll be screening so that the surgeon knows they're in the right place or whether
the liquid's going to...
Yes.
Wow.
So we do that as well.
It's really interesting. So a lot of sports people, because there's a lot of people who do sports here and have injuries. That's a good thing.
Yes, so quick access to MRI scanners. They tend to come there first.
Yeah.
Tend to come there first.
Are you excited about all these new developments?
Yes. Yes, I am, actually.
It's been quite a journey. I mean, you've been here for how long now?
We opened our first patient, I think our first scan was October 2023.
Okay.
That's our first MRI scan.
Just over a year?
Just over a year.
And how many patients do you think you've seen since then here?
I was trying to work it out. I sent the figures to David, and I think we've done about 1,600 MRI scans across the board with, 300 CTs and so many X-rays and so many ultrasounds. So, yeah.
Really good. I think it's a great thing, as I told David, to have it in the centre of town. You're part of the community, and I think that's really important, to offer a good health service to people who can come. And luckily, a lot of people who maybe can't afford it are referred to it by the GHA, which is...
Yeah, and I think the other thing, the other good thing is you have a Janita here as well. It's not just a British company opening out. Well, David's been here for 15 years, if not more, so he's part of the community. But the Janita is here as well as at the GH. So there's all of us working together.
Is your staff Janita as well, or I suppose you've got...
Yes, if they're suitably qualified, they'd be here.
Yeah.
So we admin staff at Janita's a few nurses. So, yeah.
Okay. So tell me something. What's the best advice that you've ever been given, apart from what to tell a patient when they finish, but anything else that kind of strikes a chord with you?
Professionally?
Yes, professionally.
Best advice I could give.
Or maybe something to do with basketball or something, because you're a coach, no, as well?
A coach, I can't do coach because I'll just jump on the court and do it myself, the refereeing bit. The best advice, and I think it was more to do with why I fell into radiography, is like, even though you were going that way, and I heard it the other day, and it sums it up the best way: when one door closes, there's always a window that's open. So just look for that window, and that's the best advice, just because I wasn't going to do this. I actually fell into this profession. Look at me now.
Yeah, and it was probably meant to be. Do you feel that?
Yes, for sure. For sure. It was meant to be.
And you're happy that you're back in Gib?
Yes. Wouldn't have it any other way.
Good.
No, yeah.
Well, Toni, it's really nice to talk to you. Thank you for telling us about all these machines and this equipment. We just want people to come now. Yeah. How can they get in touch with you? What is the best way? If somebody's worried about something, how can they?
All imaging has to be referred by a clinician or what we call non-medical referring practitioner, but all imaging has to be referred. So they'll have to have an appropriate referral to come to see us.
So they need to see maybe a GP or
there are some of our some physios that are able to refer for imaging. They've gone through a course and an appropriate accreditation, or a nurse practitioner. We haven't got a nurse practitioner, but it has to be an appropriate referral by an authorised person. And then we'll get the referral, and our girls will contact them and book an appointment.
And how long does that take from a referral?
It depends how quickly you get the referral. It depends which bit of imaging. MRI at the moment.
There's a queue, no? There's a waiting list.
We have a little bit of a waiting list, but we'll get through that. If it's only a knee, we can squeeze you in between patients. If it's a bit longer, obviously we'll have to find an appropriate appointment. But the rest is within a couple of days when you're done.
So you can reassure patients that if they do come here, they'll be in very good hands.
Absolutely.
Great to hear.
Thank you.
Well, thank you very much for your time.
You're welcome. Thank you.